Hi, welcome to Case Connections Unit 4 video presentation, Chem 1005, Medical Biochemistry. The next slide is an introduction video. Here I am with my name, my eyes shut, and the image that it captured. The date 9/20/20, Chem 1005, and you can play the video within the slide, within the PowerPoint presentation.
Hi, my name is Katrina Alexander. This is Unit 4 Case Connections video presentation for Chemistry, Medical Biochem, Chemistry 1005. Today's date is September 20th, 2020.
In case 1, the newborn presents with lethargy, hypothermia, apnea, and the attending physician suspects a metabolic disorder when ordering a lab panel. In this case, the diagnostic test that was listed that would best distinguish between a urea cycle disorder and a disorder in beta oxidation would be a blood glucose test. The glucose levels would be decreased in all disorders of beta oxidation due to decreased levels of acetyl-CoA as the end product that is produced as substrates for ketogenesis. Ketogenesis is an alternative energy pathway, and if it's not utilized within the skeletal muscle or the liver, it leads to hypoglycemia. It's especially essential at birth when we don't always have readily accessed glucose available. In blood glucose levels would be decreased in beta oxidation disorders, but normal in urea cycle disorders. And the next slide. This gives us a breakdown of the beta oxidation of fatty acids, and it starts here in the mitochondrial matrix, and you can see CP1 enzyme here, and it next you'll see the acetylcarnitine, and then it moves from the outer mitochondrial matrix into the inner mitochondrial membrane with the help of CPT2, and then it goes through the enzyme pathway, and you can see the end product here at the end, acetyl-CoA. And in the process of ketogenesis, as we stated earlier, the acetyl-CoA that is produced will be utilized for energy. And like we said, it is critical when glucose is unavailable. And the metabolism of free fatty acids is critical to maintaining blood glucose levels. Also, the oxidation of fatty acids produces a large quantity of ATP. The other products that are produced, such as NAD, NADPH, FAD, they're shuffled into the electron transport chain. In urine cycle disorders, glucose levels should remain normal due to the urea cycle's principal roles being the endogenous production of arginine, ornithine, and citrulline, and the clearance of nitrogen as waste from cell turnover. An elevated plasma ammonia concentration with a normal anion gap with normal plasma serum glucose levels is also indicative of the presence of a urea cycle disorder. And I had pulled this from a differential diagnosis listing of diagnostic tests from a journal that had discussed urea cycle disorders versus other metabolic disorders. Also, here we'll go to the next slide. The next slide has diagnostic testing continued, an elevated plasma ammonia concentration with a normal anion gap, as we had discussed earlier. Moving on, urinary acids and serum fatty acids could be elevated in both disorders. Plasma glutamine levels would be elevated in the urea cycle disorders due to the accumulation of the precursors of urea that are involved in the urea cycle. In this slide, it lists additional blood work findings, and the case study went on to list some additional labs that were results that were presented. And in this case, the most likely enzyme deficit would be ornithine carbonyl transferase, and the elevated urine orotate would suggest an increased production or accumulation of carbonyl phosphate. The increased levels of ammonia and carbonyl phosphate would indicate that the carbonyl phosphate is active, and the enzyme that is least likely to be impacted is carbonyl phosphatase synthetase. In this case, the increased levels of ammonia and carbonyl phosphate, like we said earlier, would indicate that carbonyl phosphate synthase is active. When the carbonyl phosphate synthase is active, it is producing carbonyl phosphate, and the OTC is decreased as the carbonyl phosphate pool is not being used to synthesize citrulline. And again, as we said, the enzyme is least likely to be impacted is carbonyl phosphate synthetase. Moving on to our next slide, this is our reference list. If you need additional references, just please reach out and I can provide those with each slide listed. And this also moves on to case 2. In this case, the infant has a presumptive diagnosis of phenylketonuria, or PKU. In this disorder, there's a mutation or a possible mutation of the enzymes or cofactors involved in the metabolism of phenylalanine to form tyrosine, a non-essential amino acid. And in this case, tyrosine would actually become the essential amino acid. And it's due to it is essential in the diet, as that it is needed for production of neurotransmitters, production of hormones, production of hormones involving the organs, production of cell growth, and without it could be cognitive deficits, developmental delays, abnormal growth. And you can see in this next sentence, I actually stated that. Potential causes of the presentation of PKU. Here in this slide, you can see the pathway in which phenylalanine is hydroxylated to form tyrosine. And turn the page. Okay. Phenylalanine is an essential amino acid, and by the hydroxylation of the enzyme, phenylalanine hydroxylase tyrosine is formed. And you can also see some other enzymes here and some byproducts, NAD, NADH, dihydropterine reductase. This is also another enzyme that if there's a deficit, which PKU could be presented. It also lists deficits in the cofactor, tetrahydrobiopterin, BH4. I apologize for pronunciations. And you can see on the left-hand side over there, biopterin, on bilateral sides where that comes into the play, the cofactors there. Moving on to the next slide. In the BH4 loading testing outcome, the administration of BH4 successfully lowered the phenylalanine in the case of patient B, and a deficiency of BH4 should be suspected. However, in the case of patient A, the levels of phenylalanine continue to rise, and a deficiency of this cofactor should not be suspected as the cause for PKU. Should probably look to the enzymes that we listed earlier, such as the phenylalanine hydroxylase, dihydropterin reductase, or dihydrobiopterin biosynthesis, as a deficit in these enzymes, preventing the hydroxylation of phenylalanine to tyrosine in that instance. And then ending our presentation, here is my reference list for case 2. And again, if you need any additional references, please reach out and I can provide those for each slide. Thank you.